The pain is crushing, right in the center of the chest, and it is spreading up into the jaw. The patient is pale, soaked in sweat, and frightened. On the monitor, the ST segments are climbing. Tall and unmistakable. This is a heart attack, happening right now, and muscle is dying by the minute. There is one drug you give in the very first minutes. What is it? Here is your question. A client has crushing substernal chest pain radiating to the jaw, diaphoresis, and ST elevation in 2 contiguous leads on the 12-lead ECG. Which action is the priority? A. Give chewable aspirin. B. Give sublingual nitroglycerin. C. Give intravenous morphine for pain. D. Apply high-flow supplemental oxygen. Pause and commit. 3, 2, 1. The answer is A. Chewable aspirin, right now. Chewed, not swallowed, whole, so it reaches the bloodstream in minutes. Aspirin blocks the platelets that are still piling onto the clot, and it is the one first-minute drug proven to save lives in a heart attack. The others treat the pain or the anxiety. Aspirin treats the clot. That is why it comes first. Here is what is happening inside the artery. A plaque in a coronary vessel cracks open, platelets rush to the crack and pile up, and a clot forms and grows until it seals the artery shut. Downstream, the heart muscle is starving, and within 20 to 30 minutes those cells begin to die. This is a full-thickness injury, which is why the ST segment lifts. Every minute the artery stays blocked, more muscle is lost. Time is muscle. So sort your actions into 2 piles. One pile changes the outcome. Opening or protecting the artery. Aspirin, now. The antiplatelet and the anticoagulant. And reperfusion. Either the cath lab or the clot buster. The other pile only eases the symptoms. Nitroglycerin for the pain. Morphine for what nitro cannot touch. Oxygen if the patient is truly low. Both piles have a place. But the drug that changes survival goes first, and aspirin sits at the top of that pile. So here is the order. First, aspirin, chewed, immediately, unless there is a true contraindication. Second, reperfuse, and beat the clock. Primary PCI, the cath lab, within 90 minutes, or, if that is not available in time, the clot buster within 30. Third, support and monitor. The second antiplatelet, an anticoagulant, and continuous telemetry, because the first hours carry a real risk of a lethal rhythm. Here is the rule to carry out of this. In a ST elevation heart attack, chew aspirin first, unless it is truly contraindicated, and then get the artery open, fast. Primary PCI within 90 minutes, or the clot buster within 30. Stop the clot, then open the vessel. So how do you know it is a ST elevation MI? On the 12 lead, you see ST elevation in at least 2 leads that sit next to each other. At the bedside, crushing substernal pressure, radiating to the jaw or the left arm, with sweating, nausea, and shortness of breath. The troponin will rise, but do not wait for it. And remember, women, people with diabetes, and older adults often arrive without the classic pain, so keep your guard up. 2 moves, and the order matters. Aspirin halts the clot that is still growing, right now, in the first minutes, but it cannot reopen an artery that is already sealed. Reperfusion, the cath lab or the clot buster is what reopens it, but it takes time to arrange, so you start both at once. The aspirin goes in immediately, while the cath lab is racing to get ready. One stops the clot from growing, the other opens the vessel. Now 2 instincts that make a heart attack worse. First, reaching for nitroglycerin without checking. If the MI is inferior and involves the right ventricle, that heart runs on preload, and nitro drops it, and the pressure can crash. Ask about recent erectile dysfunction pills too. Second, waiting to be sure, holding reperfusion for a repeat ECG or a troponin, The diagnosis is on the ST segment in front of you. Waiting only lets more muscle die. 2. To lock in. The toolkit is MONA, morphine, oxygen, nitroglycerin, and aspirin. But do not give it in that order. Aspirin is the one that changes survival, so it goes first, and the rest are conditional. And for the clock, door to balloon. 90 minutes to open the artery with PCI, or 30 minutes to the clot buster if PCI is out of reach. Time is muscle. Now the wrong answers. B. Sublingual nitroglycerin. It eases the ischemic pain, so it feels right, but it does nothing to the clot, and given blind, it can crash the pressure in a right ventricular MI. Symptom relief, not the priority. C. Morphine. It calms the pain and the patient, but it masks symptoms, lowers the pressure, and is now saved for pain the nitro cannot control. And D. High-flow oxygen. It only helps if the patient is actually low on oxygen. Pouring it on a normal saturation can worsen the injury. Tie it together. Your cues: crushing substernal pain, radiating to the jaw and left arm, diaphoresis and nausea, and ST elevation in 2 contiguous leads. Your action: chewable aspirin now, then reperfusion on the clock, PCI within 90 minutes or the clotbuster within 30, with a second antiplatelet, an anticoagulant, and telemetry. And the outcomes you are steering toward: the clot halted, the artery reopened in time, muscle saved, and any lethal rhythm caught early. Now test yourself. Same ST elevation, but this time it is in the inferior leads, 2, 3, and a VF. You give sublingual nitro, and the blood pressure drops to 78/40. What happened? An inferior MI often involves the right ventricle, and that ventricle runs on preload. Nitro dumps the preload, and the pressure collapses. Treat it with fluids, not nitrates, and always check for that inferior pattern before you give nitro. The aspirin and the reperfusion never changed. The nitro was the trap. One more. Same crushing chest pain. The troponin is positive, but the ECG shows ST depression, not elevation. Do you rush to the clot buster? No. Without ST elevation, the artery is not fully blocked. This is an STEMI, and the clot buster is not the answer, and can even do harm. You still give aspirin and an anticoagulant, then risk stratify for the cath lab, usually within a day or two, not an emergency lysis. What changed was not the pain, it was the ST segment. One last patient. An older woman with diabetes, short of breath and nauseated, and she swears her chest does not hurt. Do you relax? No. Look at the ECG and there is the ST elevation. Women, people with diabetes, and older adults often have a heart attack without the classic pain, showing only breathlessness, fatigue, or nausea. Treated exactly the same. Aspirin now, reperfuse on the clock. The missing chest pain is the trap, not a reason to wait. Next episode. The monitor erupts. A wide, fast, chaotic rhythm, the rate near 200. You reach for the wrist, and there is no pulse. Everything now hangs on one question you answer in seconds, and the answer decides whether you shock or you start CPR. That is episode 11.